So hello, my name is Clare Bailey. I'm a consultant ophthalmologist from Bristol Eye Hospital, and I'm clinical director of our research unit. And it's my great pleasure today to update you on new therapies for geographic atrophy. So, as you all will know, there are various stages of AMD, ranging from the very mildest changes, such as a few drusen, which are little yellowish deposits underneath the retina, and some pigment changes within the retina. But it's known that inflammatory processes may play a role even in the early stages. The pictures here, the bottom left shows a little bit of brown sort of focal changes, which is a little bit of the pigment clumping, and the picture on the bottom right shows yellowish deposits. These are soft drusen under the retina. But people can go on to develop later changes due to AMD. And this can be macular neovascularization, also known as wet AMD. And this is where there's an abnormal web of blood vessels that can leak and bleed. And we've had treatment for this for many years in the form of multiple intravitreal injections. But we haven't had any treatments for the dry form of disease until very recently, and that's what a lot of this talk will be about. But what is geographic atrophy? Well, that's where there are progressive dry changes such that there are atrophic patches or wear and tear patches resulting from the loss of the photoreceptor cells, the rods and the cones, the layer below the retina called the retinal pigment epithelium, and the underlying vascular layer called the choriocapillaris. And you can see here in the bottom right a little paler area in the center of the retina, which is where there are these atrophic changes, and we call that geographic atrophy. The OCT scan is very, very helpful for detecting and determining geographic atrophy. And an OCT scan is a very standard scan that pretty much everybody will get when they attend a retinal clinic. So what we can see in geographic atrophy on an OCT is that there is thinning in the area of atrophy where the retina is thinned compared to the other area. But also you can see little layers of the retina. It's a very detailed scan. You can see layers of the retina such as the photoreceptors and the retinal pigment epithelium. And in the area of atrophic change, they're abruptly disappearing. And what you get, because the light is normally scattered back up to the scanner by those layers, but they're absent, what happens is the light of the scanner transmits down a bit further into the eye. And so you get a bit like what we call a window defect, where the brightness of the light shows in deeper layers of the eye. So that's showing up very nicely the demarcation of the area of atrophic change. But we use a lot of a different sort of test in the field of geographic atrophy, and this is called fundus autofluorescence. Again, like OCT, it's a non-invasive test where you put your chin forward and your head up against the bar and we shine a light in the eye. Now, what fundus autofluorescence does is effectively measure a sort of in vivo assessment of how happy the retinal pigment epithelium is, which is the layer below the retina. So when the retinal pigment epithelium is no longer there, you get a dark patch on the autofluorescent test, such as I'm showing here. If it's unhappy, but still alive, it will show as a brighter area. We call that hyper autofluorescence. And then there's a normal sort of grayish area of autofluorescence that a normal eye would have. And it's a very good way of tracking change over time. So this slide shows the same patient over time. So the left-hand images are in the earliest time point, and the color photo shows the little patch of atrophic change, and that corresponds exactly to the area of dark on the autofluorescence. And then over a period of years, the geographic atrophy gets bigger, which you can see on both the color and the autofluorescence. And then the far right is the most recent time point where things have enlarged over time. And this is a very good way of tracking what is going on. And it's also very important to not just look at the area of the atrophy, the area that's dark, but we're also very interested now in what the area around the dark area is looking like. So what the area of hyperautofluorescence looks like. And we're also interested in the configuration, whether, for instance, the geographic atrophy is just one patch like we have here, or multiple smaller patches, and whether the geographic atrophy is already involving the center of the retina, the fovea, or whether it's away from the fovea that we call extrafoveal. And the size of the geographic atrophy also matters. And the reason that we're interested in all of these things is that these may determine the likely rate of progression of the geographic atrophy. So, as I'll come to later with the newer treatments, this may determine whether people are eligible for treatment, and we'll also be tracking how people are doing over time. So these are the sort of images we'll be showing to patients and their carers when they come to clinic to sort of demonstrate what we're trying to achieve with treatments. And we know that geographic atrophy that is away from the fovea, such as we see in this picture here, here's the fovea, and this is a patch that's away from the fovea, that grows significantly faster than if the geographic atrophy is already in the middle of the retina. So this may be a particularly good group to consider for treatment, who also would have preserved vision in that eye. And other factors, well, we know that if there are multifocal areas of atrophic change, they progress faster, and that we know that bigger areas of geographic atrophy progress faster. And then the pattern of the hyperautofluorescence around the dark patch also matters. And you don't need to know, obviously, the precise types of these, but just to say that there are particular types of pattern, one being called diffuse trickling, where there is a particularly high rate of progression. So those sorts of people or those sorts of eyes would be particularly suitable for anything that might slow the rate of progression. And people who already have geographic atrophy in the other eye are more likely to get the rapid progression in the other eye. So just to give you an example of different progression rates, and you don't need to know the exact amounts of millimeters squared per year, but this slide is illustrating really that the case on the left, where there's the single dark patch with not much hyperautofluorescence around, that only progresses at 1 millimeter squared per year. But the case on the far right, which has this particular pattern of hyperautofluorescence called diffuse trickling, that progresses 5 times faster at 5 millimeters squared per year. So whilst you don't need to know the millimeter squared progression rates, it's something that we look at as clinicians to help advise patients on the likelihood of things getting a lot worse over time. So these are important sort of pictures to understand, really. And the other thing, and I think this sort of makes sense really from a practical point of view, is that if the geographic atrophy starts to progress into the central areas of the retina, that is correlated with a decrease in visual acuity. So clearly people who have a small patch of atrophic change that's a long way from the center might not even be aware of it, have no visual difficulties in the center of the retina. But as things progress in closer and closer, then that's when the visual acuity starts to deteriorate. So the name of the game for these sorts of treatments is trying to catch things early and reduce the central visual loss. We know from real-world studies of patients with geographic atrophy, and this is work that's done by a colleague of mine, Yusha Chakravarti, and a number of units who've pooled their real-world data. We know that if you follow people up with geographic atrophy, then over several years, there can be very significant losses of vision. 20 letters is about 4 lines on the vision chart. And, quite significant impact on quality of life if people's central vision is involved. And patients, as I'm sure you know, with advanced geographic atrophy may struggle with everyday activities such as reading, cooking, driving, and recognizing faces, with a significant impact on quality of life. So GA can lead to progressive visual loss, and therefore preventative treatments to effectively slow and delay the progression to late AMD in the early stage of the disease could help to prevent irreversible visual loss. So here is a case from our unit. So the pictures on the top pictures show the right and the left eye. And 4 years ago, in 2019, this patient already had central visual loss in the right eye, but the left eye still maintained really good vision because the area of geographic atrophy was away from the center. But we didn't or haven't had any treatments up until this point. And over the 4 years follow-up, the right vision remained fairly similar. The geographic atrophy had increased in size, but there was a big decrease in vision in the left eye because this patch of atrophic change has now involved the center. So this is the sort of case where intervening early back in 2019 or even earlier potentially would, by slowing a rate of progression potentially, one could try and preserve vision for as long as possible. So in order to understand potential treatments for geographic atrophy, we need to understand what's causing it, what's going on behind the scenes. And we know it's a multifactorial disease influenced by both environmental and genetic factors. And dry AMD involves the slow degeneration of cells in the central retina. Environmental factors are important, so it's important that we all pay attention to having a good diet, not smoking, and protecting our eyes against ultraviolet light. And it's now known that several genes, including those involving the complement pathways, have been associated with an increased risk of AMD. And genetic factors are associated with the development of drusen and inflammation in the retina and the retinal pigment epithelium. So what is the complement system? Well, this is an important innate immunological network and helps with the detection and removal of pathogens. And what we mean by pathogens are things like the bacteria and the viruses that are trying to give us infections. And it's a network of soluble proteins and membrane-expressed receptors and has a multitude of effects in the eye. Now, the complement system in healthy individuals is regulated, and it stops this system attacking and damaging our own host cells, our own healthy cells. And there are a number of mechanisms in place to limit where and when complement activation occurs. But if there's dysregulation and it gets sort of acting when it shouldn't quite be, then that can lead to inflammation and death of the cells. And in AMD, complement dysregulation can allow for damage to host cells. And there's evidence of complement activation in retinal tissues in eyes with AMD, and complement activation leads to inflammation and cell death and may be very important in GA pathogenesis. In the geographic atrophy trials that have been done, the problem is the vision changes may not show results during the time frame of most clinical trials, which are usually 2-year follow-up, etc. But fundus autofluorescence has been really useful to assess progression. So that's generally used as what we call the primary endpoint of the trials to see whether the drugs are working. And this is a very active area of clinical research. So moving now on to the update of the therapies, I'm very pleased to say that there's been a lot of research going on over many years, and 2 intravitreal anti-complement therapies have now shown positive results in phase 3 clinical trials, reducing the rate of progression of geographic atrophy. It's important to note that patients needed to already have some geographic atrophy at the start of the trial. So this wasn't for people who had drusen and nothing else, and they were not permitted to have previous wet AMD in the treated eye for the trials. The 2 drugs in question, I'll tell you a little bit more about them now, is something called pegcetacoplan, and this blocks complement factor C3. This has FDA approval in the USA since February 2023 and has been used in the USA with over 60,000 vials already being used as we speak, but we're awaiting European and UK approval. And the other drug is Avacincaptad pegol, and that blocks complement C5. And very hot off the press, this has just been approved in the USA this month in August 2023 at the time we're doing this recording. So what are the data for pegcetacoplan? That's also now known as Syfovre. So this was studied in two very big phase 3 studies called the Oaks and Derby studies. And patients received intravitreal injections, so little injections into the eye of the medication, either monthly or every other month, or a sham injection, i.e. a pretend injection, for eyes that had geographic atrophy to see if it could slow the progression. And it did indeed show reductions in progression of the geographic atrophy growth in the overall patient population at 2 years. And what's encouraging, it seemed as if the treatment effect got better and better over time. So there was a particularly increased treatment effect seen in the last 18 months of the trial. Now, there was no difference in visual acuity between the groups during the trial, but of course, many patients in the trial did not have center-involving atrophy, so they wouldn't necessarily have vision difficulties. Now, the group that did particularly well was the patients who had non-subfoveal geographic atrophy, i.e. it was away from the center of the retina. And it reduced the growth by 26% in the monthly injection group and by 22% in the every other month injection group compared to sham. So this isn't improving or making the atrophy go away. What it's doing is slowing its increase that would otherwise have occurred. The GA lesion growth was also reduced in the people who had subfoveal change, but to a somewhat lesser extent than in the extrafoveal group. And in a post hoc analysis, that means an analysis after the initial results were determined, did show a reduction in progression in changes of retinal function called microperimetry in the area just surrounding the initial geographic atrophy lesion. Now, safety is always very important when we have new drugs coming out. So in the trials, intraocular inflammation occurred in 2.1% of the every other month treated patients and 3.8% of the monthly treated patients versus 0.2% in the sham group. Now, most intraocular inflammation can be well managed with drops or other treatments. And importantly, in the clinical trials, there were no cases of any retinal vasculitis. That is an inflammation of the retinal blood vessels that can sometimes lead to closure of the blood vessels or vision loss, but no cases in the clinical trials that occurred. In the trials, however, there was an increased rate of new onset wet AMD. Now, these sorts of eyes are at risk of getting this anyhow, and 2.6% of the sham group did develop wet AMD, but that was definitely increased in the treatment arm. So people who had the every other month group had a 5.5% chance of developing this, and that was 8.8% of the monthly injection group at the end of the trial. Now, real-world data is now coming out from the USA about safety. And whilst in the clinical trials there were no cases of retinal vasculitis, as of the day I'm presenting this talk, there have been 7 cases out of 60,000 or so injections where there has been some inflammation of the retinal blood vessels called retinal vasculitis. And this is something that's being looked at very closely. We don't have the treatment available to us in the UK anyhow at the moment. And so there'll be lots more information coming out over the next few months about this and how significant this may or may not be. So in summary, Syfovre reduces the rate of progression of geographic atrophy. It does increase the risk of wet AMD developing on treatment, but in the trials, patients could still receive the Syfovre and were given the anti-VEGF, the treatment for the wet, as well. There's a long-term extension study called GALE, which is collecting further data. And as I mentioned, the USA are collecting data on their adverse events and outcomes as well. So we'll have a lot more information, by the time things are registered in Europe and in the UK. So moving then on to Avacincaptad pegol, this blocks a different aspect of complement called C5. And there are 2 clinical trials called GATHER1 and GATHER2. Now, in GATHER1, there were monthly intravitreal injections for 18 months versus sham, the pretend injection. And in GATHER2, they gave monthly intravitreal injections for 12 months, and then some of the treated patients were re-randomized to receive every other month treatment after 12 months. In that trial, people were allowed to be included if they had centre involving atrophy, but that wasn't the case in the Syfovre studies. And again, very encouragingly, Avacincaptad pegol did reduce the progression of geographic atrophy in both studies. In GATHER1 at the 12-month endpoint, there was a 35.4% reduction in progression versus sham with the 2 milligram dose. And in GATHER2, there was a 17.7% reduction in progression. In terms of the safety data, this looked very encouraging in terms of inflammation. 1.5% of eyes developed intraocular inflammation in GATHER1 and none in GATHER2, and no cases in sham. But again, as with Syfovre, it does seem as if these anti-complement treatments do increase the risk of wet AMD. So 9% developed wet AMD at 12 months in the GATHER1 study versus 2.7% in sham. And in GATHER2, 6.7% developed neovascular changes versus 4.1% in sham. And as I mentioned earlier, this has very recently been approved by the FDA in America, so we don't really have meaningful real-world data here yet. So the burning question we'll all be wondering is, what about treatment in the UK? Well, we have to wait for all the regulatory approvals. So the European regulatory approval and the MHRA have to approve it. And NICE, in order for things to be given on the National Health Service, NICE have to look at it and decide if it's deemed to be cost effective. And NICE guidance would determine really who could potentially be eligible for treatment on the National Health Service. One thing I would say, and I think you will have probably got the idea of this from what I've said so far in the talk, is that we need to be very careful at selecting the correct sort of people suitable for treatment. For instance, if people already have very poor vision, this treatment is not restoring vision. So people with very poor vision would not be suitable. And perhaps the ideal sort of patients are those people who've still got good vision in an eye, that we know that they have geographic atrophy that's away from the fovea, that we know is progressing rapidly, and that if we give these injections, we can hopefully stave off the rate at which it would grow to involve the centre of the retina. And so it may well be that what we do is some monitoring with autofluorescence prior to commencing treatment to determine the rate of progression for that individual person. And then we'd be showing the autofluorescent images and discussing that with patients. And then once treatment commences, if that's what's deemed the right option, then we'd monitor on treatment to see if there was any likely treatment effect. Because if it didn't look like it was working for an individual person, there would be no particular benefit in carrying on and on and on. So these autofluorescent pictures that I showed you will be key to tracking how effective the treatments are. And it's an active area of ongoing research. So those aren't just the only two potentials. So we've got oral tablets that are being investigated that are anti-complement tablets, and there's a study which recruitment is completed, we're awaiting the results, and there's also gene therapy being looked at. So one is a subretinal injection, for instance, of something called complement factor I, which is or something would help modulate complement factor I in the eye. Studies are ongoing, and also intravitreal gene therapy aiming to inhibit the complement membrane attack complex, and studies are underway. And one of the things people often ask is, well, is there any prospective improvement if I've already lost my vision? And that's a much harder nut to crack. There's been a lot of research about stem cells, and that's under investigation in several sites around the world. So it's known that one can differentiate stem cells into various cell types of the retina and retinal pigment epithelium, and much work is underway to devise the best way to transplant those cells into the eye. For instance, they could be layered as a sheet, as a scaffold, and then introduced as a sheet, or it could be introduced as a fluid suspension and inject them underneath the retina. And studies to date have shown that the cells can survive under the retina, but we're a long way off knowing whether these treatments could actually restore any vision. So it's not something that's there in clinical practice at present. So in summary, we now have 2 intravitreal anti-complement therapies that have been shown to reduce the progression of geographic atrophy, and they have been recently approved for use in the USA. We are awaiting approval for use in the UK, and we don't anticipate that to happen until next year sometime. Regular intravitreal injections would be needed for these. This is a very active area of clinical research, so there's lots of promise for the future, and this is probably just the beginning of a new avenue of therapies. Thanks very much for listening.
Thank you, Claire. That was a really excellent description of geographic atrophy and the latest treatments. So I have a few questions, which are mainly around, how this might impact on patients. So how would you think that people are going to get referred into hospital for treatment if the optician thinks they have geographic atrophy?
Well, this is a very good point, because typically patients with geographic atrophy away from the fovea might not hitherto necessarily have even been referred in. So it does absolutely hammer home the point that very close liaison and communication with community optometrists will be key. So there are plenty of places that work very hard with local community optometrists, do lots of educational pieces. The ideal would be to have linking of imaging software so that the optometrist could upload the images on some software program that the hospital could look at and determine whether people might be eligible without them necessarily having to come for a preliminary assessment. But the educational piece and explaining both to patients and the optometrists about who might be ideal is absolutely key.
Thank you. So an optician could tell somebody if they've got geographic atrophy now? Well,
yes, they don't have quite the same imaging modalities as we do. So they don't have, most of them don't have autofluorescence, but the vast majority of optometry practices have OCT. And as I showed in the very first clinical slide, OCT is very, very good at detecting geographic atrophy. So there may be educational pieces needed for community optoms to make sure that they can spot where we've lost the photoreceptors and the RPE, but that's something they should be able to detect. And they're excellent. The optometrists around the UK are very well educated and excellent, and very commonly will refer explaining that there's geographic atrophy. And of course, in trial active sites like we are in Bristol, we've had these links for years because we've had many clinical trials for geographic atrophy over many years. So optometrists are quite often used to referring in because we might be able to include people in clinical trials, and that will be replicated in many places across the country.
Thank you. Now, in your talk, you referred to people having wet AMD as well as geographic atrophy. How do you think patients with both forms of AMD will be treated? Will they be able to have both injections at the same time?
Well, this is an absolutely brilliant question, and we don't yet know what NICE might or might not say. So just to emphasize, the clinical trials excluded people who already had wet. So we don't have clinical trial evidence for use in people who had wet before. And as you know, quite a lot of people can have dry change as well as wet changes and be on treatment. Now, the license in the USA did allow people who had previous wet to potentially be treated. So in the USA, real world data is being collected in people who previously had wet AMD treatments. But we don't yet know what the European UK license will be and what NICE will say. So that's a bit of an uncertainty. What we do know, however, from the trials is if you do develop the wet during the trial, which, as I said, is slightly increased risk of that, then you can, during the trial, they did give both treatments. So it's not contraindicated to have both at the same time. But it all comes down to effectively what the licensing will be when it comes across from the US, really.
Thank you. So when it comes down to the treatment, as you say, it's eye injections. How long do you think people will need injections for? We're used to people with wet AMD sometimes having injections for years.
Yeah. Well, this is the key, and this is what I was trying to get across in the talk. Many of the most eligible, most ideal patients will not have visual loss, and we will be showing them their autofluorescent changes and saying, gosh, well, this is what we'd be predicting might happen over the next few years if you don't have treatment. But they will be turning up, having injections potentially every other month, potentially for years and years, and they won't tangibly feel better, because the idea is that we keep their vision good. So one of the real challenges, I think, will be maintaining motivation, because people don't like having injections and they don't like turning up. Now, of course, it's such a rapidly evolving field that, yes, now we say these injections will be very regular, but we might have longer acting versions or this and that. So for now, I think we'd say we'd be expecting them to be regular, ongoing injections until either it's determined that they're not really slowing the rate of progression. And that's why having some idea about people's rate of progression sort of between now and next year when they might be available is helpful. But if it's not slowing their rate of progression, then why would one continue necessarily? But I think motivation for people when they're not aware of a benefit is tricky. And people who've lost vision in one eye may well understand better than people who've got good vision in both eyes. So I think it's brilliant, the work that the Macular Society, I think, will be doing in due course to sort of explain all that, because it's quite a subtle point, really. Yeah.
Absolutely. Thank you. Patient education is so important. So we know how busy eye clinics are now with just treating those with wet AMD. And then there's some changes going on in how we treat wet AMD in the future. But how do you imagine that your clinic, for instance, is going to cope with the extra work to treat dry AMD patients?
So there would certainly be, I mean, we don't know what NICE will say yet. So that will really determine the magnitude of the pool of people who may or may not be suitable. So it's a bit of conjecture at the moment. But let's say, with any luck, that NICE do allow us to treat a particular group of patients. Then there'd clearly be work for the ophthalmologists in the initial diagnosis and deciding and having a very careful discussion with patients and their families about whether to commence treatment. Clearly, people need to be monitored periodically for seeing how the geographic atrophy is doing. But because there's an increased risk of wet AMD, people would also need to have periodic OCT scans as well to check they're not developing wet, and also be advised to seek attention if they develop new symptoms in the meantime. So it could be that some of these treatments are done in outreach clinics, as many of us already do with anti-VEGF, and they could be injections done by the allied health professionals to try and help the workload. I think the consultant involvement would be very much at the initial diagnosis and at certain time points, perhaps every 6 months, where you're looking closely at the autofluorescence and deciding, yep, is it slowing the rate of progression? How's everybody doing? But I don't think the consultants themselves would see everybody every injection. Yeah.
Thank you. So I think a final one. No matter what NICE say, once the drug has a license, it can be given privately. Is that right?
That's our understanding. Well, it is the understanding. Now, this is where this becomes, education is absolutely key, because one of the worries could be that people are using it in cases that probably might not benefit. So you wouldn't want to be giving it if people already have very poor central vision, because all you're doing is taking the risk of each injection, whether it's a finite risk of infection, etc., getting in the eye, for no tangible benefit. And also, we don't have the evidence of treating people with much earlier disease, although it's sort of appealing to think, oh, yes, well, if we catch it really early. We really don't have the evidence that treating people who don't already have some geographic atrophy should be having it. And the problem with private practice is that sometimes there's people get desperate and there's somebody there that thinks, oh, well, I'm happy to treat you, and they won't necessarily follow the typical guidelines. That could be a concern. So I think the key message, I think, for patients is make sure who you're seeing is a macular expert, because they will understand all of the subtleties around case selection, and they will understand all the latest updates about the safety issues and the risk profile, because it's a very rapidly evolving field and there's more and more research coming out. So I would say make sure people are AMD experts that treat you in the private sector. Yeah.
Excellent. Thank you so much, Claire. That's been brilliant. Thank you very much.
Thank you.